everybody, and welcome to another ECIST podcast. My name is Erika McGinnes, and I'm an Improvement Manager with the Emergency Care Improvement Support Team. And I'm joined today by two colleagues from Leeds Teaching Hospitals who are here to share their experience with us of using a quality improvement approach to implement criteria to reside. Ali and Sheela, would you like to introduce yourselves?
Thank you, Erika. Hello, my name is Ali Cracknell. I'm a consultant in elderly medicine at Leeds Teaching Hospitals, but I'm also Associate Medical Director for Quality Improvement, and I've been heavily involved in how a large teaching hospital might implement reasons to reside or criteria to reside. And I work closely alongside Sheela.
Hello, my name is Sheela Kumar. I'm a project manager for the Unplanned Care and Discharge team.
Thanks very much, guys. And as a trust, I know, as Ali has said, that you have put a considerable effort in launching and implementing criteria to reside in a sustainable kind of fashion. So I'm really looking forward to this discussion with you. Ali, if I can start with you, I guess my first question is about why quality improvement, or why using that approach to kind of support change. So what was it about QI that kind of attracted you in that respect?
Okay, so I guess when you can see the value of something like the benefits of having criteria to reside, but you've got to engage the whole organisation, lots of different professional groups, into how to embed this in practice and how it can bring benefits to them as a team and also to their patients, then I guess I've learned over the years that quality improvement really helps you get that engagement, because it's an iterative process, really. You start to learn how teams can take a concept or a tool and adapt it to their different world. So, for example, different surgical wards, medical wards, step-down wards, all different sort of wards. You've got to learn how you might adapt something into their practice, and how they sort of learn how to do it. So who's going to do it? When are they going to do it? How do they actually complete the tool? Where are they going to do it, etc.? You sort of learn all that as you go along, and you can take that learning to help you spread and scale up something like criteria to reside across an organisation. So I guess we could see the value of criteria to reside, but we knew it was going to be a massive challenge to get a clinical engagement into using the tool. And I guess we knew if we took a quality improvement approach, we were much more likely to have success and ultimately help our patients and have sustained the process of reasons to reside. I don't know if you want to add anything there, Sheela.
I think the key thing really for us was making sure it was clinically relevant and making sure we actually got that engagement and it was used across all wards. I'm a full believer in quality improvement and having an agile process in order to adapt to any of the challenges or barriers that actually came up, and this allowed us to do it.
Ali, you've touched on, I think, two really important points, which I would like to come back to in turn. You've talked about clinical engagement, but you've also talked about the value of recognizing that one size sometimes doesn't fit all, and therefore in the implementation kind of being meaningful to kind of those groups of staff rather than just kind of implementing something as standard. So if we took the engagement side from a practical point of view, given that Leeds Teaching Hospitals is a sizable organisation, how did you go about that? What did you do in practical terms?
I guess the first thing is you create a bit of a implementation and QI team behind it. And then you're going to have those role models within that team. So it was clinically led. So we had myself as a doctor, we had Dawn as a nurse, and probably crucially, we had Amy as an AHP lead for the project.
Sure.
Working closely, obviously, with Sheela to help us keep on track, project management side. And then we work very closely with the developers, because we have an electronic patient record in Leeds. So we wanted to develop a clinically useful electronic tool. So I think the first thing is to set up your team behind the scenes for the engagement. And then I guess what we did, we would say, like quality improvement, you never go for a big bang approach, just launch something that you think and hope is going to work across the trust. We want to test small scale. So we went to wards that we knew their leaders were up for, they could already see the benefits, but they didn't know how it might work on their ward. So we went to about 5 different wards in different areas. So trauma wards, medical wards, admissions wards. Went to those wards to say, you know, how do you feel about helping test this out in your world? You know, which staff are going to be key to filling it in and completing it? How are you going to do that in practice? And possibly more importantly, how's it going to change the conversation you have at your board round or your MDT? Because that's really the point of it, isn't it? We want to change the culture so it makes a difference to patients. Anything to add, Sheela?
Just to say, we picked wards that had been involved in quality improvement projects previously. So some of them had done really well with ARCs. And because they understood the concept, we thought we'd get some easy, quick wins with some of our wards, and then we'll focus on the more challenging wards who might need a bit more assistance and a bit more support. But if we had a promising pilot, then that would be a really good place to start.
And then those wards then start to tell their story to engage the other wards. So it's less top down. It's like, well, actually, we didn't know how this could work, but we were happy to give it a go. But actually, it has helped us. And these are the benefits. And then it helps get their neighbouring wards on board and etc.
And so much better, isn't it, peer-to-peer rather than top-down kind of from an organisation. I think one of the exciting things I'm hearing you share is that you had no preconceived ideas entering into the project. And in certain cases, I guess you let the project tell you, or the outcomes certainly from your pilot wards, tell you where the next steps to explore would be. So there's something, I guess, for me in that respect about the iterative approach to change. So how have you developed and evolved your approach over time? So how have you, I guess, enhanced the value of criteria to reside in that respect?
So I've probably already described it a little bit. We started with 5 pilot areas, if you like. And as you know, we worked also with Mid Yorks Trust as well. So that gave us learning in a different organisation as well to share ideas. And we started to learn with those teams. I mean, part of it was actually getting a clinically useful tool that works within our electronic patient record that can be easily filled in by clinicians, and then learning how that can work in real time. So how can they fill it in whilst they're doing the MDT or the board round? And then how are they using that information to do things differently for patients or help flow? So I guess we learned that. And every ward is different. As you know, Leeds has 92 wards and Mid Yorks has probably 25, I think. So you've got to be comfortable to let the team sort of adapt and you learn from them. So you might have preconceptions, well, I don't think it will work doing it like that. But actually you learn if that's how it works for them, that's fine. And then you can shape those ideas to form sort of, we had like a launch plan, didn't we, Sheela? Once we'd got 5 wards testing, we then scaled up to about 10 wards to just feel more comfortable before we went for a trust-wide launch. And then Sheela put a lot of effort into developing the materials to engage and communicate about how we go sort of live quite quickly from there. I don't know if you want to build on that, Sheela.
After we trialed it with our pilot wards, they came back and we tweaked some of the terminology from the criteria, and it was really helpful. We attended some ECIST events, and there was suggestions about how to make it a little bit more clinically relevant for our wards, and just a little bit easier to understand for the wards using it and filling it out. And I think that helped clear up some of the confusions that was initially caused with our first pilot. And one of the things that I think really surprised all of us is the wards came up with their own benefits of using the tool. And so they spread what they found best about the tool, and it was things that we hadn't even thought of. So it was really useful in that way.
And then we recorded them, didn't we, Sheela, sort of telling their story to help engage. Yeah.
And I think with the faculty, because we had a cross-section split across the hospital, we had discharge coordinators there up to matrons up to, so it was a huge split, and everyone, had a voice, and everyone could feedback on how it was relevant for them, and what they found useful about it.
That's really, really good to hear. So 10 months in, I think, more or less into that journey, what's next for you? So has the data shown you anything of value that you want to do differently as a result?
Yeah, so I guess data is key as well to keep the engagement going. So I guess in Leeds, we're in a pretty good position that the data is used widely now throughout the organisation. So that helps clinicians know they've got to keep it up to date, because if the data is not accurate, it's pointless. But how we're using it in the organisation helps keep it flowing, if you like. So managers are using that information on a daily, if not hourly basis, which is helping patients and flow in the communication. So it's things like, even as consultants, I will know every day how many patients either on my ward or my department have no reason to reside. And then the internal delays get escalated. And rather than me trying to work out how to escalate today these delays, people are coming onto the ward, seeing what the delays are and proactively helping us solve them for the day. So I think how you use the data is really key. We're about 97% of patients have a valid, up-to-date reason to reside recorded, which is really powerful. Mm-hmm. And I think that's because the organisation is using the data at all levels. So different teams will use it. So the safeguarding team, for example, every day will review the safeguarding delays. And so they're proactively onto that at 8-9 in the morning rather than waiting for people to ring them. Therapy teams the same. Anyone waiting a therapy decision to support discharge, they can look at that 8 in the morning and they can move their workforce to help move those patients quickly through that possible delay.
So that electronic information is definitely helping proactive behaviour then, by the sounds of what you're sharing.
Yeah, one truth, if you like. So yes, a snapshot that's visible at ward level for everyone, and then reports that say what's going on at the organisation. And then they can drill down into what the delay is and some free text comments. So if they really want to know what's going on with, say, a safeguarding issue, they can see why that the free text comments without needing to ring the ward or speak to 10 different people about what's going on. There's sort of one version of the truth. Yeah,
absolutely. So I think, Sheela,
so what also helped was we got the system buy-in as well. So the system's updating pathway 1, 2 and 3, and there's a weekly process of validating the information to make sure that the patients are waiting for what it says they're waiting for, and the wards are kept up to date with what the patients are actually, what the internal delays are, what external delays are.
So internal and external relevance, which I guess makes the effort all the more important, doesn't it? Because then everybody's benefiting from that information, which is inputted once, but actually helps along a much broader journey. If I had to ask you for your top 3 tips for trusts considering going down the same route as implementation, what would you say to them?
Okay, firstly, I'd say clinical leadership's going to be key, and those people have got to work very closely at the beginning with the developers of the tool, especially if it's going to be electronic. So the worst thing you can do is develop an electronic tool and then ask people to complete it. You've got to work together to begin with. I'd say be brave, sit back and let teams sort of adapt it. Don't assume it has to be a certain level of person who can complete the tool. Anyone can do it, and it's about learning who's the most appropriate person for that area. And thirdly, I'd say work out what's in it for clinical staff. So learn what works for them. So with us, the biggest thing they'd say is it's reduced interruptions massively. They're not constantly getting phone calls about who's waiting for what the delays are. So learn what's in it for them really quickly, and then celebrate and use the data to make it embedded within an organisation. Anything you'd add, Sheela?
for me, it's just start small, try some, plan, do, study, acts, find out what works clinically. It's similar to what Ali said.
That's really helpful, guys. I think that's all we have time for today, but clearly there's a lot more that we could be talking about, both in terms of quality improvement and also in terms of criteria to reside, which, as you both described, is an evolving journey and hopefully something that not just yourselves, but other organizations can keep building on from time to time as well. So thank you very much for your time today, and we'll see you very soon.